everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health, reporting for the week of September 29th, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. After an update on COVID, respiratory illnesses, measles status, I will talk about a few MMWR reports from the CDC regarding flu of last season and the upcoming season, as well as go over a new study regarding COVID and loss of smell. First, starting off with an update on respiratory viruses and measles. Taking a look at respiratory viruses, the percentage of positive tests in a clinical setting, we can see that SARS-CoV-2 in the red is making up a decreasing share of those tests, and an increasing share is due to rhinovirus, enterovirus, which is one of the most common causes of the common cold. And taking a look at COVID in the wastewater, we can see that it is also declining here for the most part. So nationwide, which is represented in black, is moderate and declining. Good to see that the South and the West are declining pretty sharply. Midwest also declining. The Northeast looks like it's heading up a bit. But when we take a look at things on the map, we can see that there's high COVID activity really in many places across the country. So it's pretty variable. So the two darker shades are very high, and the many states are also moderate. And then there's a few states there that are low or very low. And when we look at it in terms of epidemic trends, even though it was high in many of these states, we can see that it's also coming down almost in every state. So the darker green is declining, and that other green color is likely declining. So almost the whole country is declining or likely declining in terms of COVID epidemic trends. Remember, this is looking at emergency department visits for COVID and giving us an idea of which way things are going based on that early indicator. And so the only state that appears to be likely growing is Arizona at this time. And hopefully everywhere else, hopefully we'll just continue to turn green all across the nation soon before it heads back up, likely in the winter. And taking a look at hospitalization, we can see that this is also coming down. So this is definitely a good sign. Hopefully that will be it for this summer wave, and hospitals will just come down from here, but we will continue to keep an eye on it. And it is pretty variable from state to state. So if that's something you're interested in taking a look at, the link to check it by state is in the post. And for some reason, this slide still has not been updated. So this is unusual. The CDC has adopted a new surveillance page, which I've linked in the post, and they've changed the way that they're displaying deaths. But this is unusual. This has been updated weekly for a very long time now. And so for whatever reason, we haven't gotten any update since September 6th, when there were 185 deaths. And we have been having pretty much all-time lows for the last few months now, really. So hopefully that will hold. And taking a look at measles, we have an additional 23 cases compared to when I reported last week. So the measles situation just continues. In the United States, we are now at 1,514 total cases, and that's compared to just 285 in the entire year of 2024. And remember that it's not just a potentially life-threatening and generally miserable, potentially dangerous acute infection, but it also can wipe out prior immunity and can even have a debilitating late complication that I went over in a couple of weeks ago, if you are interested in learning more about that. Next, I wanted to share the recently released morbidity and mortality weekly reports. They came out just a few days ago on September 25th, and there were actually 3 of them that are highly relevant, giving us a look back at the 24-25 flu season, as well as looking forward to the upcoming season. The first report is regarding flu-associated pediatric deaths for the season. And another one covers a terrible complication of flu, the flu-associated encephalopathy. And the third is regarding effectiveness estimates of the vaccine for the upcoming year in preventing illness. So I've linked all three reports in the post, and I'll go over them briefly today. So those who have been watching the briefing throughout the flu season know that it was a particularly bad flu season by pretty much all accounts. And a couple of these reports certainly seem to confirm that. Most striking is that the season saw the highest number of pediatric deaths reported since child deaths became a nationally reportable event, which was back in 2004, with the exception of the H1N1 pandemic year in 2009. So this past flu season was the most pediatric deaths that we've had in 2 decades outside of that one pandemic year. There were a total of 280 pediatric deaths, which is devastating no matter how you look at it. It is worth noting that a little less than half of the children who died from flu had no underlying medical condition at all. And almost 90% of them were not fully vaccinated against flu. So this indicates that many of these were likely preventable deaths. So not a surprise, but the flu-associated mortality rate was highest among children under 6 months of age. So we talk a lot about the vulnerability of the extremes of age. And of course, the under 6-month-olds are not eligible to receive the flu vaccine. So this is a major reason why we encourage the flu vaccine in pregnancy. Deaths were also higher among girls than boys. And the highest mortality rate in terms of the racial breakdown occurred among children who are Black or African American. So Black children accounted for 23% of all pediatric flu deaths, which definitely highlights a terrible disparity since Black children make up only about 13.9% of children in the United States. So this is a significant overrepresentation by more than 1.5 times their population share. And this is sad and a significant disparity, which is something we always want to be looking at when we are talking about anything that affects us at a population level. The median age at the time of death for these children was 7 years old. 61% of the deaths were among children under 9 years old. And the clinical course for these children was rapid. The median number of days from the start of symptoms to the time of death was only 4 days. About half of the children who died had not been admitted to a hospital at the time of death, so they died either in the emergency department or somewhere outside of a medical facility. Children who died outside the hospital were less likely to have an underlying medical condition. And for those children, the time between symptoms and death was even shorter, with a median of 2 to 3 days compared with 7 days among those who had been hospitalized. And also a relatively small percentage of those children received any antiviral treatment. So the main limitation cited for this report was that deaths are likely underreported due to potentially not identifying or diagnosing flu or attributing death to another cause, even if it was flu, or just simply not reporting the flu. So as devastating as all of that was that I just reported, it's still likely an undercount. And next, we move on to the unfortunate situation of an apparent increase in a terrible neurologic complication of the flu called Influenza-Associated Encephalopathy. So we actually started to hear anecdotal reports about this from some of our local hospitals back in January or February. But because this complication is not a nationally notifiable condition, it was hard to determine whether these were just anecdotes or a local issue or whether it was a widespread problem. So thankfully, these and other health leaders brought this issue to the attention of the CDC, which then began actively requesting notification on this condition from health departments and clinicians. And so now we have this MMWR report that discusses the situation in detail. So we know that flu can cause neurological complications, although they're generally thought to be relatively rare. And influenza-associated encephalopathy, or IAE, is a recognized complication of flu that is related to a severe inflammatory response. The most severe form of IAE is called acute necrotizing encephalopathy, or ANE. So ANE disproportionately affects children. It leads to very rapid neurological decline that can result in permanent deficits, and it can be fatal. There were 109 influenza-associated encephalopathy cases reported during the season. And again, we really don't have historical information on this to compare it with, but it does appear to be an uptick just based on the reports that even prompted the request for additional reporting from the CDC in the first place. 55% of the children with IAE were previously healthy with no underlying medical conditions. And upon their presentation to the hospital, these children typically had altered mental status, along with the respiratory symptoms and fever that we can see with flu. About 45% also had seizures. The neurological symptoms started rapidly, approximately 2 days after the onset of the flu-like symptoms. And all of these children had abnormal brain imaging. About 3/4 of them were admitted to the ICU. And tragically, 19% of all of the patients with influenza-associated encephalopathy died, so 19%. And this actually went up to 41% for the acute necrotizing encephalopathy subset of the cases, so that more severe form. And sadly, less than half of those who survived have returned to their neurological baseline. And of those children for whom vaccine information was available, only 16% had received the influenza vaccine. So this is a very sad report. It contains a lot more detail if you're interested. The biggest limitation here is that this is not a comprehensive data set. So unlike the general flu data that we just went over, which also had some underreporting involved, but with this, there's no mandate. There's no mandate for reporting IAE or ANE, meaning that this is almost certainly an undercount and will not necessarily include all of the clinical information that might be useful. So this is obviously very terrifying. The advice is essentially the same, that annual vaccine for everyone 6 months and up is recommended. But I also think it's important for parents and clinicians to know that this complication exists, so that if there appears to be any mental status changes in a child with flu or flu-like symptoms, especially during flu season, this should be a cause to seek emergency care immediately. I am also pleased to report that the CDC will be integrating surveillance for IAE and ANE into its surveillance systems for the 2025-26 influenza season. Hopefully, this will improve our understanding and tracking of this terrible complication. And very briefly on this third MMWR report, it's about estimates for the effectiveness of the influenza vaccine that we plan to use for the upcoming 25-26 flu season. And we base the vaccine that we're going to use for the next season based on the Southern Hemisphere season, this is our routine method for predicting and determining the flu strain composition for the Northern Hemisphere vaccine. So the bottom line here is that the flu vaccine was estimated to have significantly reduced flu-associated illness. The study included over 200,000 people across 8 countries in the Southern Hemisphere during their flu season, March to September 2025, and found that the effectiveness of the vaccine against influenza-associated outpatient visits was 50.4%, and against hospitalization was 49.7%. So reducing medically attended flu illness and hospitalizations by about half is considered to be quite effective. So since these vaccines were effective in the Southern Hemisphere season, this is the exact composition plan for the Northern Hemisphere 25-26 flu season. So we should be able to anticipate similar effectiveness for the season coming up. And many places are already administering the flu vaccine. And once again, everyone 6 months of age and up is eligible and strongly recommended to receive the vaccine. And now I want to turn to a recent publication in JAMA Network Open about a topic that is not as common as it was in the beginning of the pandemic, but still comes up from time to time, and that is the loss of smell following COVID-19 infection. So one of the things I like about this study is that it does not rely upon patient self-report to assess the smell loss. It actually uses an objective 40-item scratch and sniff test. The study looked at almost 3,000 enrollees and was performed across 83 sites in 35 states and territories in the United States. And there were a couple of interesting findings here. So first is persistence, the persistence of the smell loss. So 80% of the participants who reported a change in their sense of smell were still scoring abnormally low on this objective smell test about 2 years after the initial infection. And the second is the hidden impairment. So a striking finding in this study is that 66% of participants who had COVID but did not notice any change in their sense of smell still scored abnormally low on this objective smell test. So we know that the loss of smell can interfere with taste and generally be a quality of life issue, but it can also be a safety issue because we rely on our sense of smell to detect dangers like fire or gas leaks or spoiled food. So before we get to the implications, I'll briefly touch on the why. So why is there a persistent loss of smell associated with COVID-19? So multiple studies suggest that long-term smell loss is not caused by the virus directly affecting the nerves that help us to smell. Instead, it's an ongoing inflammatory response. So the tissue that contains our smell nerves basically gets infiltrated by immune cells like T cells, causing persistent inflammation. This chronic inflammation actually damages that tissue and causes a decline in the number of smell nerve cells. So it seems to resemble kind of like an autoimmune-like process that keeps the tissue from regenerating function even years after the virus has cleared. So first-line treatment up until now is still what is called olfactory training, which includes exposure to distinct odors to help kind of rewire those damaged nerve pathways. But there are also some promising therapies on the horizon that we'll be tracking, like platelet-rich plasma injections to help to regenerate the nerves. I think it's also worth noting that this complication does not seem to be occurring with nearly the same frequency as it once was. We all remember the early days of COVID when losing your sense of smell was pretty much like a hallmark of infection. Back in the alpha days, the prevalence was estimated to be as high as 60%. With Omicron, it has significantly dropped, and it's now estimated to be somewhere between 3 and 17%. But still, for those who develop this persistent smell loss, it is strongly correlated with broader neurological and cognitive issues. And I've linked an article about this in the post. The olfactory system, the sensory system that allows us to smell, may be kind of like a window into the central nervous system impacts of SARS-CoV-2. Studies have shown that a persistent loss of smell is a predictor of some cognitive issues, including problems with attention and problems with memory. So all of this is to say that we should be thinking of smell loss as much more than just an inconvenient aspect of long COVID or just a quality of life thing. It should prompt an evaluation for other neurologic and cognitive symptoms. And so back to the recent study from the Recover Consortium, they confirmed long-lasting impairment with 80% of those who reported smell changes still having them an average of 2 years post-infection. And then secondly, they confirmed that for many, this is a hidden impairment with 66% who did not notice any issues still scoring abnormally low on the objective test. So the bottom line is that this olfactory dysfunction or loss of smell after COVID is surprisingly persistent and can go undetected without formal testing. So the authors conclude that formal smell testing may be considered in those with prior SARS-CoV-2 infection to diagnose these undetected cases and to counsel patients about risk and particularly other neurologic associations. They acknowledge the challenges of rolling this out, though, because it's a pretty in-depth kind of objective test, and the number of people getting COVID infections is so high. But this does certainly warrant further exploration. The study is large, it's one of the largest out there using an objective measurement. And it's important for confirming those couple of factors, the persistence of the dysfunction and the fact that it can go unrecognized. So I do think this is an important addition to the literature. Hopefully, we'll continue to raise awareness around what may be a crucial indicator, maybe even kind of like a canary in the coal mine for other neurologic consequences of SARS-CoV-2 infection. So it is good to be learning more. It's good to be seeing more published. And in many ways, it continues to reinforce what we know. We want to continue doing what we can to keep ourselves and our loved ones safe. And remember, we want to do what we can to avoid infection and reinfection. Just in general, we still are dealing with increasing cases of long COVID and recognizing other post-viral chronic conditions more and more. So it is a best practice to avoid infection and reinfection. If you don't feel well, test to rule out COVID, especially if you're someone who should get treated, but just in general, so that you know and that you can hopefully keep from spreading it to others. And if you don't have a primary care provider, please get one. Make a treatment plan for COVID and for flu. If you need one, make sure you're getting vaccinations, age-appropriate screenings that might be particular to your family history. Have these conversations with your primary care provider. And if you're sick, please rest and recover. Otherwise, get outside, get some regular physical activity, get some fresh air, eat a balanced diet, and stay well hydrated. Let's avoid those simple sugars and processed foods and artificial ingredients, limit alcohol consumption, and quit smoking. And remember to manage those stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you next Tuesday at 10 a.m.